You're listening to the Assembly on Critical Care podcast, brought to you by the American Thoracic Society.
Welcome back to the Bedside, everyone. This is a ATS podcast where we discuss commonly encountered problems in the ICU. Today, we're discussing tracheostomy during critical illness with a focus on timing, technique, benefits, and complications. We're really lucky to have Dr. Elliot Backer on the show, who's an assistant professor of medicine at the Geisel School of Medicine at Dartmouth University. Dr. Backer, welcome to the show.
Happy to be here. Thanks for having me.
Wonderful. As a reminder to everyone, the content here and the opinions represent only that of Dr. Backer and myself and don't necessarily represent that of the American Thoracic Society or our respective institutions and is not specific medical advice. To get started, Dr. Backer, could you give us a little bit of your background and what you do in your day job?
Sure, happy to. So I am the Director of Interventional Pulmonology here at Dartmouth Health, which is way up in beautiful New Hampshire. And aside from the different service lines that we run on the interventional pulmonology side, my team also assists with performing percutaneous tracheostomy and PIG in our ICU setting, particularly the medical ICU. And we also are one facet of our multidisciplinary surgical airway service, which is a new program here at Dartmouth begun in the last year to help streamline our best practices and care of those with trachs in our hospital to be more in line with recommendations put forth by the Global Trach Collaborative.
Awesome. Well, it sounds like you have quite a bit of experience managing and placing tracheostomies in addition to an advanced airway skill set. So it sounds like you're the perfect person to have and appreciate your time.
Absolutely. Let's get into it.
All right, cool. So without any additional delay, let's get into our case. So we have a 53-year-old woman with past medical history of hypertension who presented to the hospital with influenza pneumonia and acute hypoxemic respiratory failure. She developed ARDS and was intubated for her respiratory failure and finds her way to your ICU. It's currently day 5 of her intubation and her respiratory failure is stabilizing. However, she remains on moderate support from the ventilator and on a significant amount of sedation. Her current ventilator settings are ACVC rate at 25, tidal volume of 380, a PEEP of 12, and 75%. In the context of her respiratory failure, how do you think about indications and benefits of tracheostomy, Dr. Backer?
Yeah, so this is a great place to start. And this is a pretty common clinical vignette that I'm sure you and all the listeners are pretty familiar with. You can think about the indications for trach, of which there are numerous. And this situation obviously paints a good story for the patients that we see in our medical ICU who we evaluate for trach for prolonged invasive mechanical ventilation. But I think it's also good to take a step back and take a little bit more of a holistic approach, which is what I try to do in thinking about who would be a good candidate for trach. Why or why not? And I think this decision, really like anything else that we do in medicine, needs to be well formulated. It needs to be accompanied by a thoughtful decision making of weighing not only the risks and benefits of the procedure, but also asking the tougher questions that are sometimes harder to do. So, number one, what is this tracheostomy going to afford us and the patient in this moment? Setting the expectations for the patient and their family about what a trach will do or not do. What is this going to accomplish? 2, is this in line with the patient's goals of care? Does this make sense for that person? And 3, we need to talk about what comes next. And it's easy for us, especially in the ICU when somebody's sick, to focus on the immediate. How do we get them out of trouble? How do we get them through this admission? How do we get them out of our ICU? But tracheostomies may commit patients and families to pathways that they also may not have envisioned or expected, particularly depending on where you live, what the local support resources that you have access to are. So for instance, I work in New Hampshire, which is at Dartmouth. We are one of the, if not the most rural academic medical center in the country. We have exceedingly few options when it comes to where we can send these patients to for recovery. And that has profound impacts on the conversations that we have with families, and so all these things, really do need to be discussed. And when we're having those initial conversations with families, now is the time to do it.
Wonderful. I think that's a really excellent point. And when placing a tracheostomy, you're setting someone off on a pathway is really well taken. If you kind of put your proceduralist hat on, let's say you're consulting for one of my patients, are there things that you generally like the primary team to have discussed with the patient and family prior to walking into the room?
Also a really good question. I always ask when someone calls me for a trach evaluation, is the patient or the family aware that I'm going to come by and actually chat with them about this? Sometimes we come by and it is a bit of a surprise for them. So have you set the stage for these conversations? What have you talked to the family about? How have they responded? Have you had those goals of care conversations? Because if you haven't, I'm about to, and this patient better than I do. And so this is also a good opportunity to have a kind of collaborative multidisciplinary conversation with the family that not only involves me, but the primary team. So setting the stage of the trach and the risks and benefits are helpful. Sometimes what our patients find or the families find to be the most surprising that they aren't aware of until they speak with us might be something like, hey, this trach may not necessarily fix the underlying problems. It may serve a purpose, but it's not necessarily going to make them better. Other things that they're often surprised about that are helpful to tell them early, and that goes back to what are the resources you have in your community and in your state, is where are they going to go to once they leave the hospital with this trach? Sometimes families will say, well, my loved one may only want a trach if they're going to go home and be with their family and animals at home, but they don't necessarily realize that, well, they have rehab in their future. They have an LTAC in their future. And some of those may be non-starters for a lot of families, especially here in more rural communities. And so those are important things to get out of the way early and just have that discussion with the patients and families.
Right. That guidance totally makes sense. So let's say in this context, we've discussed with the family because she's unfortunately still sedated and unable to participate in the conversation. And her family thinks that even if it was associated with a long stay in an LTAC or a rehab facility, that she would want to pursue tracheostomy as a bridge to recovery from her respiratory failure. When you start thinking about timing of tracheostomy in the course of respiratory failure and critical illness, how do you think about it? When do you think is the right time to place a tracheostomy? 5 days is fairly early in her course, but if we wait too long, perhaps we're running the risk of causing injury to the vocal cord and airway. How do you approach the timing?
Yeah, so also a really good question. And one of those things that's been a hard nut to crack if you go back and look at the data over the last several years, but we can start to paint a story for what probably makes sense. So, if we go back in time to some of the earlier prospective RCTs done in 2004 that looked at early, which again, you have to look at what the definition of early and late was in the studies, but early, which was 48 hours versus late, 14 to 16 days tracheostomy. A lot of those early studies, some of them at least, showed reduced ventilator time, reduced ICU lengths of stay, improvement in rates of ventilator-associated pneumonia in the early groups. And so I wasn't practicing them, but I'd be curious to go back in time and see what the practice patterns were there, because fast forward to studies coming out in 2010, which are becoming larger and more robust, now maybe starting to compare VAP rates in the early versus late group and not showing any significant difference. And then that really brings us up to 2013. And 2013 was one of my favorite studies around that time, and it's hard to imagine that that's already 11 years ago. But that was the TrackMan or TrakeMan trial. They spell it TRAC, so I just call it TrackMan, like Pac-Man. But that was a really important study to talk about when we're discussing when should we consider trach. This was a multi-center RCT across numerous teaching institutions in the UK, and they enrolled hundreds of people, upwards of 1,000 patients, requiring invasive mechanical ventilation, who were intubated for no more than 4 days. And then it was for people who the providers at the time of enrollment felt were most likely to remain intubated for an additional 7 days. And they were randomized to either early trach within those first 4 days or late after the first 10 days. And what they found was no difference in 30-day mortality, ICU length of stay, hospital stay, duration of invasive mechanical ventilation. And one thing that we didn't talk about yet was, but what does trach actually get you? And, there's lots of variation in the studies, but one of the common themes that routinely comes up as here's what trach affords most patients, it's less sedation and being more comfortable. And that's what they showed in this study. And I think it's important to note that in that study, the TrackMan study, 92% in the early group received their trach, whereas only 45% in the late group actually got trached, which my takeaway from that was, as a medical community, and certainly myself, we kind of stink at guessing who's going to require prolonged invasive mechanical ventilation. And so my practice is pushing that 10 to 14 day mark before we start those conversations, particularly when we're talking about our medical ICU patient who's going to require trach for ongoing respiratory failure and other MICU associated issues. I brought with me a quote, which if you'll oblige me, I'll read, but it was from the lead author of this study that was given at an ICU symposium. And it just does a really nice job of wrapping up this trial. But he said, if you had 100 patients requiring tracheostomy, doing it early results in 2.4 days less sedation overall, but you would perform 48 more with 3 more procedural complications and no effect on mortality or ICU stay. So I think that statement underscores the importance, like everything. The decision to perform a trach needs to be a calculated one, weighing the risks and benefits and patient-centered at its heart. But the short answer would be 10 to 14 days.
Beautiful review of the literature, and I really like the quote as well, and appreciate you bringing it. It really puts it into perspective what the tracheostomy affords them. Now, another question: does that vary at all if the indication for tracheostomy isn't in the context of respiratory failure? Like, let's say that I see a fair amount of patients with brain injury. If someone is not intubated for respiratory failure but is intubated because of their mental status, does that change your timing at all, or were those patients included in the studies you mentioned?
Yeah, also a really good question. And I'm sure, those listening who spend time working in a neuro ICU or with those with various brain injuries and pathology, those who spend time working in a trauma ICU, they're going to see some of this in a different light. Their patient population is at its heart a little different. The prognoses and times to recover are a little different. And so I think it's fair to open up the kind of conversation to, is it different in the neuro ICU? Is it different in the trauma ICU? And I think practice is a little different. I spend most of my time working in the medical ICU, but I certainly talk to my colleagues who work in those other parts of the hospital who see a different patient population, and their approach to trach is a little different. If we think about those with brain injury and who may find their way into a neuro ICU, to my knowledge, there are small amounts of data available to help guide a lot of this decision making. There was a 2012 RCT that hinted at possible reduced ICU time in early groups in those in the neuro ICU. But there was also a larger 24 meta-analysis that showed no improvement in the early trach group. But I think if you talk to people who anecdotally spend their time in the neuro ICU, I think they'd be the first to point out, like I mentioned, that there's high variability and often protracted times that it may take these patients to demonstrate meaningful clinical recovery from their illness. And understanding that unique nature of the prognostication, like you mentioned, that they're dealing with, which can be very different from what we encounter regularly in the medical ICU, certainly factors into their decision making about timing. And some of them will opt for earlier trach placement if that's what clinically fits the situation they're dealing with. And the trauma folks, again, to my knowledge, and I apologize if there's any more contemporary data, please let me know, but there really only are small case series and cohort series in this population that kind of help guide best practice. So some of those studies show likely reduced vent and ICU time in the early trach groups, especially in those with multi-system blunt trauma, severe TBI, like we were talking about in the other group. Overall, the research that exists in this population is pretty heterogeneous for sure, with some conflicting results depending upon what you look at. But it's also important to appreciate, like in the neuro group, that the baseline protoplasm of a lot of the trauma patients that we see here may differ, widely from those in the MICU. The otherwise young, healthy person who got into a really bad car accident, as compared to the comorbid cardiopulmonary patient we see in our medical ICU. So, the decision to perform earlier trach in these individuals with multi-system trauma, again, like everything we talk about, especially when it comes to trach, should be kind of carefully weighed on an individual patient characteristic, basis based off of those things.
Appreciate that explanation. It seems like your position as someone who directs, tracheostomy service line is in a really interesting position to hear a lot of different practice patterns and work in a lot of different care environments. So thanks for sharing that. And I think your point is well taken, that prognostication is challenging, and I think in whatever endeavor, and resolution of respiratory failure and neurologic recovery and overall prognosis, I think are really challenging. And I think how to share those uncertainties with the family is really an art and really important to prioritize. If I can, I'd like to change gears just a little bit. This has been really helpful. But when we get down to placing the tracheostomy, the two main approaches I am familiar with are the percutaneous tracheostomy that's frequently done in the intensive care care unit at the bedside versus a surgical procedure that's frequently done in the operating room. And I was wondering if you could briefly explain those to us and the pros and cons of either approach.
Absolutely. All right. So when it comes to trachs, there's exactly like you said, there's two main categories: surgical trach, perc trach. Even within the percutaneous tracheostomy category, it's probably important just to touch upon that there are different techniques that are implemented and studied. So there's one that's called the Griggs method, which uses a dilator forceps that helps create the stoma and introduce the guide wire into the trachea. There's the Dolphin balloon-assisted system, and this is marketed as a single one-step device that uses a dilating balloon, which provides a radial dilation across the stoma to form it, and then allows for simultaneous tracheal tube insertion. Again, kind of marketed as like a one-step shop kind of tool. And then there's the Blue Rhino system. This is, I apologize if there's any others out there, but this is probably the one that most people who perform percutaneous tracheostomy or have it at their institution are probably more familiar with. And this is a modified Seldinger technique and relies on serial dilations to create the stoma and use of a large tapered dilator that's inserted prior to placement of the tracheostomy tube. And this is some that I use. I guess you could call it sort of a hybrid approach, where I'll make a vertical incision through the skin and then blunt dissection down to the level of the trachea prior to making my first puncture into the airway, and then use the Blue Rhino system from there. And I think any of these systems, offer their own unique advantages. And at the end of the day, what's best? Well, I think whatever's best is whatever can be done fastest and safest and most efficaciously. And then there's the surgical trach. So open or surgical tracheostomy, as you'd imagine, involves dissection through the soft tissue and then an incision directly into the trachea to create the surgical airway prior to insertion of the tracheostomy tube. This is often done by our surgical colleagues, and although it could be done at the bedside, it is, I would imagine, most commonly done in an operating room setting. So, when we talk about weighing the risks and benefits of either approach, here's kind of like a 10,000-foot comparative view, and then we could get more granular from there. But there have been several comparison studies that exist in the literature, and a good one is from Chest from 2003. And here's just kind of the bullet point punchlines. There's no difference between surgical and percutaneous trach. There is no difference in mortality. Percutaneous trach has a shorter procedural duration, although every time I say that in a PowerPoint and there's a surgeon in the room, their hand usually goes up right after I say that. Percutaneous trach often has better cosmetic results. For a lot of our patients in the medical ICU who are really sick, that may be lesser of a distinction, to make. Percutaneous trach is cheaper, although it depends on where you do the trach. So the expensive part here is the operating room time. And there have been cost analyses that have looked at what is more cost effective. And the most cost effective way of doing a trach is a surgical trach at the bedside. The problem is that I would imagine at most institutions, our surgical colleagues may not be comfortable with that. Why do it there if it can be done in an operating room where they have their equipment and their staff and et cetera, et cetera. So I get it. But otherwise, percutaneous trach is cheaper. Another just practical thing is that it's a bedside procedure. It avoids transport of a critically ill patient across your hospital to the operating room. If you have somebody who's on ECMO or whatever other support with lots of tubes, go ask any nurse or RT how they feel about trekking across to your operating room versus doing something at the bedside. And it's pretty clear they prefer to do them at the bedside if safe and possible. The bleeding risk is equivalent or potentially less in percutaneous trach compared to surgical trach. The infection risk is equivalent or less in most studies. When we're talking about complications, I break those down into early versus late. Early complications being air in places it shouldn't be, whether that be subcutaneous emphysema, pneumomediastinum, pneumothorax. Bleeding, of course, is the biggie. Bleeding risks are for either is typically upwards of 5% and usually on the minor side. The risk of decannulation, creation of a false passage. Infection risks for both are typically in the ballpark of under 1%. Late complications, those include things like granulation tissue, post-tracheostomy tracheal stenosis, which is something that keeps me busy and these patients down the road. Those are 1 to 2% risks. Tracheomalacia, and of course the dreaded Tracheo-Innominate fistula. The very last thing I'll mention about the post-tracheostomy tracheal stenosis is that the incidence of that with surgical versus percutaneous tracheostomy is about the same, although it could happen sooner in patients who undergo percutaneous tracheostomy, on average of 5 weeks versus those who get a surgical trach, where you see it more often 28 plus weeks out.
Got it. Well, really appreciate the description of both the techniques and then the early and late complication. I want to jump into complications, particularly in the immediate post-procedural setting. But one quick question regarding the procedure in your practice. Before, it sounds like your modified approach, do you do a ultrasound the neck to look for any vasculature, any vessels in the area that you'd be performing the tracheostomy?
Yeah, thanks for asking that. That's a really important question. So this kind of brings us back to patient selection. And I think it's important to just say, if you are starting a percutaneous tracheostomy program, if you're new out of IP fellowship, or this is something that you're learning to do and you're going somewhere, you don't want to have bad outcomes, right? Nobody does, but you want to be judicious about who you're offering this to at the bedside and being thoughtful about identifying those who may have higher risk of bleeding because of their vascular anatomy, and, reaching out to your surgical colleagues to take those cases, if you're concerned. And so how can we kind of help triage some of that a little bit? Well, one is I always look at the cross-sectional imaging that's available to us. So if there's a CT, and better yet, a CT with that was done of most often their chest, but also including their neck, then I'm looking at that. I'm looking at where my likely insertion site's going to be. I'm looking at their thyroid. I'm looking at their vasculature. Do I see a high riding innominate? And then, yes, to answer your question, I definitely do a point of care anterior neck ultrasound prior to every trach that I do. What am I looking for? Mostly what I'm looking for are what is the burden of, perforating, jugular veins. We're looking for the inferior thyroid vein. We're looking for those anterior jugular veins. We're looking for the perforators, maybe a high brachiocephalic if I see one. Have there been any RCTs performed in this space? No, but there are some systematic reviews. There was one by Kohlig in 2020, and they demonstrated that ultrasound evaluation may change the insertion site in 17 out of 72 ICU cases and reduce the risk of bleeding complications. And there are definitely times where, based off of what I'm seeing, if I'm seeing a high burden of vasculature in my intended insertion site, that's immediately anterior and right where I'm going to be going and dissecting through, plus maybe other bad features the patient may have, like, hey, this is also just a generally coagulopathic patient, and that's the patient I'm going to hit the pause button, and I'm going to reach out to my surgical colleagues.
Wonderful. Thanks for reviewing that. As an intensivist, there's two complications that I really fear when someone is post-tracheostomy. And the first is bleeding, and the second is the tracheostomy becoming dislodged or coming out in some way. And I was wondering if you could give us your approach to both of those, and then also kind of tailor that towards what someone who's a general intensivist or a pulmonologist might be able to do who may not have your advanced skill set.
Yeah, early bleeding, early cuff issues, early dislodgement questions and concerns. These are the things that keep us up at night. They also always happen to occur at 2 a.m, as you know, but these require immediate attention. This is a danger zone when we're talking about early trach complications. The question we're really asking with an early trach is the stoma formed? Is it mature? Can that trach come out and be replaced if necessary? And there's variation in sort of when people are comfortable removing a trach and putting it back in. And it varies by patient and their wound healing. But in general, anything under 7 days, we need to proceed with caution and assume, especially at 2 a.m, that this is not a mature stoma. So why don't we start with bleeding? Bleeding is probably the more common complication or issue that we're going to run into after a trach, especially in an ICU patient, especially in those who are coagulopathic, they're in renal failure, they're otherwise anticoagulated, et cetera, et cetera, et cetera. This is not uncommon. And then what we're really talking about is early bleeding from around the trach site. Typically speaking, this is capillary in source. Like we talked about how there are perforating jugular veins around it. There's lots of capillaries there, but it's typically a capillary bleed. And there are some things that we can do to assess this and treat it. It's also the reason that I like to do a vertical incision and not a horizontal one through the skin, just keeping in mind that the trachea is a midline anterior structure, and we want to stay away from those more lateral vessels. So bleeding around the trach. A good packing around the site can help, but of course, if the bleeding's ongoing and you're soaking all of your gauze, you may have to take down the dressing and evacuate that clot to really see what's going on under there. Questions that I'll ask when I get called and I'm not at the bedside is trying to get a sense of how much bleeding has happened. Sometimes you can do an indirect way of getting at that by asking, well, how many times have you replaced the dressing? If they tell me, well, I've replaced it a dozen times in the last hour because it keeps soaking, we've got a problem here, folks. Is there blood coming up from within the tracheostomy tube? Is that where the bleeding's coming from? And that may signal other issues. And then also, how's the patient doing? How's their gas exchange okay? Is there a clot that's formed that's made its way down to the distal end of the trach that's obstructing it? Once a year, once every other year, I'm called to a respiratory arrest in somebody with a trach, and only to find out that there's actually some blood clot that was obstructing or something else. So if there is any respiratory issues, try passing that soft tip suction catheter to make sure there's no obstruction. As far as management goes, of course, look at the underlying coagulopathies. What else may be predisposing to ongoing oozing if this is an ongoing problem? Don't underestimate the bleeding power of a high BUN in our renal patients with high BUNs. I'll consider DDAVP if this is an ongoing issue, not responding to local therapies. You can try some hemostatic agents, Surgicel, some TXA soaked gauze, and really get it underneath the flange of the trach and kind of get it up around the edge of the stoma. I've also tried some local injections of lidocaine with epi around the stoma for the vasoconstrictive effects. That can help. It's usually a bridging. Usually it'll work for a little bit, and then unless other things change that promote clotting, they may start oozing again. In cases where this is an ongoing problem, I just need to take down all the dressing, evacuate all the clot, and see what's going on. If the incision is a little bit too long, that patient might need another suture put in. If this is just ongoing bleeding and there's a little edge of that stoma that just extended a little bit too far for the trach itself. Or you can take a little silver nitrate stick or other forms of cautery, depending on who's available and around to help you with those things, and treat around the stoma if necessary. So all of those things can help, and especially in our coagulopathic patients, sometimes all those things are necessary. I think it's hard to talk about bleeding without talking about TI fistulas or Tracheo-Innominate fistulas, because that always needs to be on your mind. So any bleeding from within the trach, to me, after post-op day 3, but what's the literature say is 75% of those cases are really going to occur after the first week. So most are happening in weeks 1 through 3. It's pretty early for that to happen in the first 2 or 3 days. But just to be safe, really after those first 72 hours, if you're getting blood up from inside your trach, at least start to think about it, because this is a rare but dreaded life-threatening complication. The innominate is a branch of the aorta. It crosses from left to right across the trachea. Around the 9th tracheal ring, there's lots of variation. That's about 4 to 8 centimeters below the cricoid. And the risk factors for a TI fistula are 2 things. It's somebody who's got a high riding innominate, and had a low placed trach. And if you've got those 2 things together, then your risk factor for this just went up. And it's caused by erosion of the cuff or trach tip through the anterior tracheal wall and into the vessel. So in about a third of those cases, often what you're going to hear, especially in those classic cases, is the patient has a sentinel bleed. All of a sudden, there's a big rush of bright red blood through the trach, and then nothing. And you go in to see the patient, they look okay, the blood's been suctioned, they're not actively bleeding, and then you go about your night, and then 2 hours later, you're called to the code. The mortality for these with treatment is over 50%, and over 50% of survivors of this are going to be dead in 2 months. So this is a big deal. Without treatment, the mortality is 100%. So my workup to these patients is, if they are stone cold stable, then I may start with a stat CTA imaging of the neck and chest, but I am also contacting the appropriate surgical services. We're not waiting, even if nothing's going to be done. So who you call is also dependent on what availability you have at your institution and who does what. Are your cardiac surgeons comfortable with this? Are your thoracic surgeons comfortable with this? Do your vascular surgeons treat this? Do your ENT surgeons treat this? So you need to understand what your local expertise is and start calling those people. And keep in mind that CTAs and bronchoscopies may have high false negative rates, and that this is an airway surgical emergency until proven otherwise. If they're unstable, then the horse is out of the barn. And now imaging does not supersede surgical management. So these are stat surgical consults. And the very first thing that you should do, if there is blood coming up from the trach itself and you are concerned about TI fistula, is hyperinflate that cuff. Most of the bleeding was usually at the level of the cuff of the trach. Not always, but mostly. And in most cases, the data would show that this can be effective in at least slowing bleeding. This isn't treating it, but this is a Band-Aid to it, something more definitive. So hyperinflate the cuff, you want it rock hard. Now, if that is not helping and you are still having a lot of bleeding as you are getting your surgical colleagues on the line, And the next thing that you need to do is you need to intubate from above. That's also assuming your patient can be intubated from above, but assuming they can, remove the trach and your finger goes in the stoma. And now you're going to perform what's called the Utley maneuver. The Utley maneuver is putting your finger kind of like a fish hook into the trachea through the stoma. It's directed caudally, and you hook anterior to compress the innominate against the posterior aspect of the sternum. And now you are lifting hard. So that person is on the bed, pulling up with all their might, and you are probably going to go to the OR in that position. After that, what happens again depends on what you have available to you locally. If you have good vascular surgery capabilities and endovascular capabilities, then there is a role for endovascular repair and stenting as a kind of lesser invasive approach. And this is the more favored, if possible, temporizing treatment. And then after that, you're going to need some form of definitive management, but that comes next. That may include trach revision, creation of a muscle flap between the tracheal defect and the artery. If you don't have endovascular repair capabilities for this at your hospital, what you're talking about is an exposure via median sternotomy and ligation of the artery. And emergency surgery with these, again, the mortality is well over 50%. So that's kind of the bleeding spiel from the mild to the ugly. And then you asked about trach dislodgement, which is, this could also be a real serious issue if that happens early. My initial questions are, what kind of trach is this? What size is it? Is it sutured in? What's the status of it now? How is the patient doing? Are they maintaining reasonable oxygenation and ventilation? Is this somebody who is kind of already just about off the vent or totally off the vent and they were a real quick wean within the first few days? So what kind of an emergency are we dealing with here? But what we really care about is that stoma matured? And you have to assume that it's not, especially if it's more premature than the first 5 days, but you need to exercise a lot of caution in those day 5 to 7. Let's say it's 2 a.m. and you're by yourself and you're in the ICU and this is an early trach that's less than 7 days old. And let's assume that stoma is not mature. That's the assumption that we have to make. The first thing to do is do not just blindly reinsert it. And the reason I say that is because what we don't want is a false passage where the trach dissects through the soft tissue in the chest just anterior to the trachea and you're not going to ventilate them. You've just lost your airway. So when in doubt, first question is, can my patient be intubated from above? Was this trach because of an upper airway obstruction? Now we've got other issues. But if they can, then intubate them from above, remove the trach, occlude the stoma, and make sure that balloon is distal to the stoma when you put it up, and live to fight another day. The trach can always be revised when you have all the necessary resources at the bedside. We can deal with it then, stabilize your patient. When it's day 5 to 7, there's a question of cuff rupture that needs to be addressed or trach dislodgement. When the patient either stable or we've stabilized them from intubating from above, now our options may expand a little bit. If I'm going to start messing with this trach and I am concerned that the stoma may not yet be mature, then I'm either just intubating the patient to just give me a secure airway while I do this, or I'm having somebody ready to intubate at the head of the bed. I've got drugs ready to go. The airway box is next to them. This is not something where you want to lose your airway and then just start yelling for help when no one's around. So stabilize the airway or be ready to immediately stabilize the airway. I'll inspect the stoma. How does it look? How does the tissue look? I may try to pass a soft tip suction catheter, see how well it goes without obstruction. Things that I may try a bronchoscopic replacement of the trach through the stoma with direct visualization of the airway. That may make me feel better for sure. And otherwise, you could also utilize an exchange catheter or a bougie. This should pass with ease. And if you're going to do it that way, then you also want to make sure that you're ready to go with other forms of confirmation, putting a bronchoscope in, passing a soft tip suction catheter through the trach to make sure it's not obstructed, looking at your ins and outs on the vent, looking at your end tidal. But again, I'm not doing this in the very early trach. This is not the appropriate next step for the trach that's less than 5 days old, certainly. In those cases, just intubate your patient, include the stoma, and we can revise the trach later.
Phenomenal. Those were just two excellent approaches for the complications that I think that we all certainly fear. And I don't know much to add to that, but one comment I might make is you can tell how much you rehearse these complications and prepare for them, particularly in the event of a Tracheo-Innominate fistula. It's a relatively rare event, but you can tell that you have prepared yourself and, if not done actual simulations, but walked through the steps, rehearsed maybe while you're driving in the car, like what you would do in this situation. So when that infrequent emergency comes, you are ready to rise to the occasion, which you really saw how much you've thought about that come through in those explanations. So thanks for sharing those with us.
Yeah, I think you bring up a really good point too. And you said the word simulations. And if you're around trachs, if you're managing trachs, do you have an emergency airway response team? Should you form one? Who is that team? What do they look like? And we do ACLS for practicing how to do CPR. These are airway emergencies that, you could argue really require their own dedicated simulations and training, especially if you have teams in play. So it is food for thought. And this would be one of those spaces where, doing those simulations as a team and at least knowing, or having some protocols in place could be really important.
Totally agree with you. I think simulations that include different specialties, different professions tend to be the most valuable. So this is certainly right for that setting. Let's get back to our patient. So she ultimately did have a percutaneous tracheostomy placed at the bedside. She did well with the procedure and thankfully didn't suffer any complications. Her ICU course progressed quite nicely, and it seems like she's making some significant progress towards getting out of the hospital. But Dr. Becker, I was wondering if you could tell us a little bit about the normal trajectory for a patient that leaves our ICU. What happens after they're discharged? What do we know about that recovery?
Yeah, thanks. This is a really important question because it also touches back to how should we be framing this for patients and families when we're having the initial conversations of should we trach, yes or no. So to answer this question, though, I want to talk about a really important paper and a shout out to Annika Law that was published in the AATS in March of 2022. And if you perform trachs or talk to ICU patients about receiving trachs, then you should take a look at this paper. It was days out of institution after trach and gastrostomy placement in critically ill adults. And this was a retrospective cohort study. It was a MedPAR review of thousands of ICU patients receiving trach and or trach and PEG. And there were over 3,000 patients looked at in each group. And they looked at two important things. They looked at days alive and out of institution, OI, and they looked at mortality. And in the trach only group, the median 90 days alive and out of institution, so median 90 days alive and out of institution was 3 days. At 180 days out, the days alive out of institution was only 35 days. The 1 year mortality for these patients was 62%. In the trach and PEG group, the numbers are very comparable. The 90-day days alive and out of institution was 0 days, with a 1 year mortality of about the same 64%. So patients spent few, if any, days alive and out of an institution in the 90 days after their procedure. And whereas in-hospital mortality was relatively low for a lot of these patients, over half of these patients were dead by the first year. If you look at a little more closely at the data, what I will say, kind of going back to patient selection in different groups perhaps, was that there was a more robust response or more positive finding in the non-morbid, non-frail pre-ICU health state patients. So the patients without frailty, perhaps your younger trauma patient, tended to do a little better. But these were ICU patients across all different ICUs, looking at thousands of patients. So I think that this is a really important thing to keep in mind. I think these numbers are important to be aware of. And when you're talking to patients, and this study changed how I talk to patients about trach. And when I'm asking a family member, what would be an acceptable outcome, they should understand what the next 90 or 180 days out is going to look like, and to keep in mind just the high mortality, that this population faces. So, they'll get out of your ICU, but what's ahead is really a much different story for them.
Right. I think that puts what we do day to day really in a nice context, and I think really drives home that point that you made right at the start. I think very appropriately as to what would the patient want, what would their goals be, and what's acceptable, because that study certainly shows that our patients are in for a long run, even when they leave our ICU doors. So thank you so much for sharing. To finish up, you mentioned that you are part of the advanced airway team at Dartmouth, and I was wondering if you could just share what that experience has been. What does your team look like? Where do you find it helpful? And if some of the listeners are interested and inspired, how they might go about creating such a team?
Yeah, sure. Happy to. So the first thing I'll say is please take inspiration from our creating this team, but this is a new program for us. And before this year, we didn't have anything. So there are lots of programs out there who have been doing this well for a long time, but it took a respiratory therapist and some nurses to kind of say like, hey, there are areas for improvement here. This wasn't put together by me. It took our RT team and some of them to say, there are some areas, some opportunities for improvement that we can make here when it comes to the management of trach patients really across our hospital. Like these patients have some of the longest length of stays, more so than anybody else as a whole. Anybody here who cares for trachs in their hospital could probably attest to that. And it's easy for me to get sort of bogged down in my world where I'm putting a trach in and managing them early, and then they're kind of going on to do other things and lose track of what is that longitudinal care and process look like for them. And there are best practice guidelines. There is the Global Trach Collaborative that puts out some low-hanging fruit that's probably real easy to implement into your own practice as a multidisciplinary team. And these can be RT and nursing driven interventions that are real simple to do and provide formal structure and organization to your trach management. So these then help us ensure that we're hitting benchmarks put forward, that include, has the trach been changed at a certain time? Have they been moved from a cuff trach to a cuffless when the time allows? Are they meeting with the appropriate consulting services, PT, OT, speech medicine, etc.? Are they up and moving? And has anyone tried a trach capping trial? Here's what this has been shown to do. Not here yet, but in studies looking at when you implement these things, does it matter? And it does. It reduces cost of care. It reduces overall length of stay. It gets them decannulated sooner because someone's paying attention and sort of asking the question of, should they be challenged yet? It reduces the time to first verbal speech. It reduces the time to first PO intake. It improves patients' quality of life. It's associated with improved staff and family education for trach care. So again, lots of low-hanging fruit. That's probably not too hard as a project for you or someone at your institution to take on.
That's wonderful. Thank you for sharing. And those really hit some important areas, is moving the care of the patients forward, which is a particularly difficult patient population to ensure really that we're continuing to push patients to get better in the hospital setting. So Dr. Backer, I can't thank you enough for your time. This was incredibly informative and inspiring to identify areas of improvement that I think that we can take as a whole. And really thank you for sharing your time with the ATS community, and hope you have a great rest of your day.
Yeah, thanks very much.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.